effort between the Journal of Neuro-Oncology and a bunch of other neurosurgeons, and where we highlight recent publications in the Journal of Neuro-Oncology, and we talk to the authors about the rationale behind those studies, the results of those studies, and really the relevance behind them. And today we're super happy to have Megan Parker and Raj Mukherjee with us today. Um, Raj, Megan, why don't you go ahead and introduce yourselves and then take it right off?
Sure. So, Randy, Jason, Christopher, thank you so much for having us. It's always a pleasure to interact with the Journal of Neuro-Oncology and to especially in these forums. Over time, I remember seeing these kinds of forums as a resident, and now as a faculty member is just a real honor to be here. I will also say, for the Seattle Science Foundation, I learned so much from the Seattle Science Foundation. I went to so many courses, and very grateful to just be on this forum with them and with all of you. So my name is Raj Mukherjee. I'm an associate professor of neurosurgery. I focus on brain tumors at Johns Hopkins. And over the last couple of years, I've had an opportunity to work with a really outstanding medical student, Megan Parker, who's in a research year, I believe between her second and third year. Is that correct? She's a powerhouse, and so it's hard to know. You would think she'd be a fourth year, maybe even a junior resident. But we had we meaning Megan, I really had the idea of trying to look at some of the basics in terms of how we approach brain tumor treatment and therapy. So, there are places, all of our institutions, do really cutting edge, wonderful work in trying to advance the field forward in terms of molecular medicine and new advances in technologies. But Megan really had the idea of, trying to look at the basics. And in terms of the basics, one of the things that even I see day to day is the interactions that I have with oncologists, radiation doctors, and even primary care physicians seems to have an association with how patients are doing. And so we wanted to try to dig into that a bit more. I think if you look outside of neurosurgery in surgical oncology fields and in other multidisciplinary fields, there seems to be an association or an interest, at least, in trying to have more coordinated care. It's something that is much more easier said than done. All of us are extraordinarily busy. We have hundreds of emails a day, we have meetings, and somehow we're expected to balance all of that. And despite having help with residents and advanced practice providers, there's a huge amount of emphasis on trying to get it all done. And so what we wanted to try and look at is, in a scientific and rigorous manner, try and assess the association between the connections between neurosurgery and primary care, and see if the strength of those connections might be associated with coordinated care, the start of adjuvant therapy, the completion of adjuvant therapy, and even trying to get a sense of whether there is an association with longer term outcomes, including overall survival. So that was really the thrust of the reason why we were interested in this topic. And I think Megan's done a great job in terms of putting it all together. So with that somewhat long-winded introduction, Megan, it was a pleasure to work with you on this, and please take it away.
Awesome. Thanks so much for that introduction, Dr. Mukherjee, and for everyone here for the opportunity to share this work. Really excited. So I'll go ahead and share my slides here. So Dr. Mukherjee gave a great introduction, but I'll just kind of sum everything up. The title of the study was Exploring the Impact of Primary Care Utilization and Health Information Exchange upon Treatment Patterns and Clinical Outcomes of Glioblastoma Patients. Starting with some brief background, as many of us are familiar, glioblastoma is the most common malignant brain tumor with a dismal 5-year survival rate of about 7%. Given this poor prognosis, therapies are often pursued with the goal of reducing morbidity while preserving neurologic function and maintaining quality of life. And the STU protocol is the standard of care therapy for patients with glioblastoma. Briefly, this involves maximal safe resection, followed by 6 weeks of concomitant chemoradiation, and then 6 cycles of chemotherapy alone. And in their 2005 New England Journal of Medicine paper, they demonstrated that this therapy improved overall survival for patients with glioblastoma. And we know that the oncologic management of GBM poses several challenges, including the time spent going to these appointments to receive chemo, to receive radiation, my mistake, as well as the side effects of chemotherapy, declines in neurocognitive function, as well as the added challenge of managing other chronic conditions. So many groups have attempted to answer the question, what factors impact oncologic management for patients with glioblastoma? And several prior studies, including some conducted by our group, have demonstrated that socioeconomic factors such as race, ethnicity, and age are associated with treatment patterns and survival in patients with glioblastoma. But the challenge with these factors is that many of them are not modifiable. However, in 2018, Chandra and colleagues reported that insured patients with glioblastoma who had primary care physicians had higher rates of treatment with temozolomide and radiation, as well as a 50% increase in overall survival. And I've added the Kaplan-Meier figure here demonstrating that survival benefit. Interestingly, however, the study was primarily focused on insurance status. But aside from this study, there's limited literature evaluating the impact of primary care and care coordination in the management and survival outcomes of patients with glioblastoma. But taking a step back and looking at other extracranial cancers, studies across these cancers have demonstrated a role of primary care physicians in the management of cancer. And they've demonstrated that primary care offers increased diagnostic opportunities and avenues for specialist referrals. Primary care physicians facilitate conversations between patients and family members regarding cancer. And they also help manage side effects of chemotherapy and radiation. And some studies have demonstrated a survival benefit of primary care physicians in patients with cancer. So, as Dr. Mukherjee kind of alluded to, there's many different ways that care may be coordinated between PCPs, oncologists, and surgeons. One of these avenues is health information exchange, which is technology that allows healthcare providers to securely access and share patients' clinical and administrative information electronically, either within one hospital system or between different institutions. So the primary aim of our study was to further evaluate the impact of primary care on the treatment patterns and postoperative outcomes of patients with glioblastoma. And then we also wanted to touch on health information exchange and see if this had any impact on postoperative outcomes as well. So we included 374 patients who were adults with pathology-confirmed GBM who underwent first-time surgical resection at our institution. We excluded patients with a Karnofsky performance score of less than 70 to match the STOOP cohort, primarily because our primary outcome was completion of the STOOP protocol. We also excluded patients who received neoadjuvant therapy and patients with less than 3 months of survival postoperatively. Just getting into the study definitions briefly. So we included a wide range of primary care physicians, from providers with MDs to nurse practitioners and PAs. And then to define health information exchange, we define this in two ways. First, either the primary care physician, surgeon, and oncologist were all at our institution and therefore use the same EMR to communicate, or the primary care physician, neurosurgeon, and oncologist were at different institutions but used Care Everywhere, which is a feature of our electronic medical record, to share electronic health information. So our primary outcome was adjuvant therapy, and we divided this into four subcategories. First, the initiation of concomitant chemoradiation, the completion of the chemoradiation, initiation of maintenance temozolomide, and completion of 6 cycles of temozolomide. Our secondary outcomes are traditional short and long-term outcomes that are typically evaluated in clinical studies of glioblastoma. This included hospital length of stay after surgical resection, discharge disposition either to home or not home, 30-day hospital readmission, and overall survival. I bolded the last 3 outcomes because these are a bit longer term, and we hypothesized that primary care might have more of an impact on these as opposed to length of stay. And then getting into the statistical analysis, I'll just highlight that for our survival analysis, we use Kaplan-Meier, and we also performed multivariate models controlled for clinical and molecular markers associated with survival in patients with glioblastoma. And the inclusion of molecular markers is kind of what really distinguishes us from this Chandra study that I mentioned earlier. So moving on to our results, I'll just go through the cohort characteristics. So the age was an average of 58 years, which is younger than the national average of patients with GBM, likely due to our exclusion criteria. There was a male predominance. Our patients were predominantly white. Most patients were married and had private insurance. The majority of patients resided in state. About half of the cohort was retired. I'd like to note that we collected these data prior to the 2021 WHO diagnostic criteria, so we did have a spattering of patients with IDH1 mutated tumors. About 20% of the cohort had MGMT promoter methylation, and the median follow-up time was about 14 months. Looking at the primary care and health information exchange variables, so 81% of our cohort had a primary care physician, the majority of whom had MD degrees and were located in state. Between the diagnosis of glioblastoma and last follow-up, patients had an average of 1.9 encounters with their primary care physician. 72% of oncologists were affiliated with our institution, and about half of the cohort had health information exchange between primary care physicians, oncologists, and neurosurgeons. So moving into our bivariate analyses of our primary outcomes. So I'll just say off the bat, electronic health information exchange was not significantly associated with adjuvant therapy here. But looking at primary care, we found that a higher percentage of patients with a primary care physician initiated chemoradiation, completed 6 weeks of concomitant chemoradiation, initiated temozolomide, and completed the 6 cycles of temozolomide. Similarly, we also found that patients with a primary care physician completed more cycles of temozolomide and spent a longer amount of time receiving adjuvant therapy overall. We also found that patients who initiated chemoradiation had more encounters with their primary care physician following the diagnosis of glioblastoma than those who did not. And then moving on to our secondary outcomes. So interestingly, we did not find that primary care or health information exchange were associated with these shorter term outcomes, including hospital length of stay after surgery, 30-day hospital readmission, or discharge position. However, in Kaplan-Meier analysis, both primary care and health information exchange were associated with improved overall survival. And then finally, we have our multivariate analyses. So again, we found that while having a primary care physician was not associated with shorter term outcomes like length of stay, discharge, and 30-day hospital readmission, we found that in multivariate analyses, having a primary care physician was associated with increased odds of initiating and completing the 6 weeks of concomitant chemoradiation, as well as initiating and completing 6 cycles of maintenance temozolomide, as well as overall survival, improved overall survival. So some takeaways here. Primary care was associated with initiation and completion of adjuvant therapy and improved survival in both bivariate and multivariate analyses, which suggests a potentially important role for the integration of primary care physicians and improved coordination between providers in the management of patients with glioblastoma. We noted that patients who initiated adjuvant therapy to any extent had more continuity of care with their primary care physician, suggesting a role that primary care physicians may play in managing side effects of chemotherapy and radiation, though this remains to be further explored. And the novelty of our study is the evaluation of health information exchange and the treatment patterns and clinical outcomes of patients with glioblastoma. And we did find a survival benefit of health information exchange in the Kaplan-Meier analysis. And we recognize that there might be technical challenges with adopting electronic health information exchange, but our study highlights the potential important role for electronic health information exchange in improving outcomes for these patients. So some limitations. Our study really only evaluated if health information exchange was available, not necessarily if it was utilized by providers. And we weren't able to quantify how frequently providers access this information. We also didn't assess verbal care coordination methods such as telephone calls or emails. And then we acknowledge that we might have missed some primary care encounters in our electronic medical record. So for future directions, we believe that future perspective and interventional studies are warranted to more fully describe how electronic health information exchange is used to care for patients with glioblastoma. And we also believe that future studies are warranted to assess the role of health information exchange and enrollment in clinical trials following surgical resection of GBM. So here we propose potential interventional study with 3 suggested conditions. First, just the existence of electronic health information exchange. Secondly, having electronic health information exchange with reminders for providers to review this information each visit. And then finally, a combination of having the electronic health information exchange as well as a clinical nurse who can serve as a communication like conduit between providers. Other studies have looked deeper into health information exchange, have assessed these outcomes listed here. So we propose also looking at the impact of health information exchange on testing redundancy, costs, and treatment delays for patients with glioblastoma. And I'd like to say thanks again to the Journal of Neuro-Oncology and the Seattle Science Foundation for inviting us to present this work. And thanks again to Dr. Mukherjee and the Neuro-Oncology Surgical Outcomes Lab, specifically our co-authors listed here. And I'm excited to discuss this further.
Thanks so much, Megan.
Yeah, thank you.
You know, I'm sure primary care physicians are really excited about this study. Super thrilled that they're contributing to the longevity of these GBM patients. I wanted to ask you and obviously Dr. Mukherjee and the team, what do you think comes first? Is it a bias of a patient who follows with a primary care doctor that they're just a better patient, they're going to do better? Or is it building a team, someone who's going to make sure you're getting your appointments, who understands your potential side effects and what the treatment is? In your impression, after looking at this, what do you think? Is there a way to tell?
Yeah, I think it's really hard to tell. The honest truth is it's probably a combination of both, but I do get the sense that, just anecdotally at least, again, hard to pull from the data, but I do get the sense that there is this subset of deeply invested primary care providers that are able to pull in patients that otherwise may have gone astray. And look, a patient's proclivity, to follow up or not is inherently something that is, going to be, they're going to do what they're going to do. But I do get the sense, and my impression is that it's probably a small but reasonable proportion, maybe 10-15% of patients, where a deeply dedicated primary care provider can truly pull them along in ways that we as busy neurosurgeons honestly can't. And even other providers like oncologists that are, very dedicated to longitudinal care, I don't think they have the bandwidth necessarily or the longitudinal relationship to pull them in. And so I think it's probably a balance, but I get the sense that, maybe a slight leaning towards primary care docs actually pulling in patients and moving them along. At least that's my hope.
Yeah. I think the real interesting or extremely interesting part of this, as we enter into a more and more digital age, becomes transferring this information. And obviously HIE is a component with Epic. We use an app here that was developed by Dave Langer called Playback that allows us to record things, and the patient has it, can share it. Should we be looking at like a blockchain health record that just goes with the patient, where you show up and your whole medical history is downloaded or uploaded? What does everyone think?
Yeah, I definitely think that there ought to be some more portability to EMRs. I mean, there are principally 2 large EMR systems You were using one. There's another large system that competes, and those systems don't talk well to each other. And the other challenge, which I think we've all, we as neurosurgeons face, is the access to pertinent imaging studies. And those imaging studies reside oftentimes on other systems in other formats, and are just are quite essential. So there ought to be some more common conversion rates or conversion platforms that allow that information to be easily transmitted. And I think you've hit the nail on the head, Megan and Raj, with regard to this, just the importance of health information exchange and care coordination with a good PCP. But there are just so many other things, as you've indicated, in the potential future experiments, and arguably can we use AI, because we all know that how busy we are, not just as neurosurgeons but as primary care physicians. They're just inundated with information. How do we have things fired at the appropriate time, or taking a 10-page note and distilling it into the most pertinent things, or making it particularly searchable? But I think what your work showed is it can really make a difference in various endpoints, and I'm most impressed by the work you've done.
Yeah, I agree. I think that is the big push there. The moment is that you actually extend people's survival by doing this. And so figuring out a way to convey that information, and truthfully, it's not just making sure these companies talk to each other, it's making sure providers read the info, which is why having it in a digestible format makes a lot of sense. But please, Megan, Raj, floor is yours. Comment.
Yeah, I definitely agree with that. I think having some, as you said, a blockchain that follows the patient. I think I also really resonate with your comment about it being digestible. I think having this there and then just having a bunch of alerts on the EMR is probably not the most productive way to get this across. So being able to carry an electronic medical record with the patient that's not necessarily distilled, but, most like engaging to the provider, I think would really, as we've shown here, improve outcomes, but also reduce costs and redundancy, which are extremely important given like costs of medical care, especially in neurosurgery and neuro-oncology.
Yeah, I think this stuff. Go ahead, Raj. Sorry.
I was just going to say, I remember years ago, maybe he still gives the same talk, but Rick Komatar would give a talk about building a practice. He wrote a book about it too. And in that, he talked about his approach to building a practice. And he would apparently, like after he was done with surgery, after he saw folks in clinic, it was just a sort of a quick text message. But he did note, like, it took a huge amount of time to do that. And he's built a huge practice. But yeah, using AI or different automated methods to try and operationalize what he does, and what I think each of us try to do, would be extraordinarily helpful. It's I think a lot of our findings are maybe intuitive, but they're modifiable, and if it impacts survival, that's a huge thing. The last little bit I would say is there are mechanisms within PCORI and AHRQ in terms of funding mechanisms to try and look at some of these types of interventions in terms of the broader survivorship research model. And so hopefully that's the kind of thing that our group and others can pursue in the coming years.
Yeah, you want to repeat who's that for again? Who's that through again?
It's from AHRQ, the Agency for Healthcare Research and Quality, as well as PCORI, the Patient Centered Outcomes Research Institute.
Yeah, so often we focus on high-tech solutions to looking at what's the latest, greatest precision medicine approach to making a difference in patient outcomes, and there are some basics, right? Good communication, health information exchange. Do you have someone who is helping you as a primary care provider? And I mean, just some basic things that can make a world of difference, as your study showed, and probably makes even more difference in terms of the overall, caregiver satisfaction, their quality of life, their overall satisfaction. I mean, these are unfortunate patients we're frequently not curing, but how do we measure and quantify those things too? Because we could take a $50,000 precision medicine approach or something like that, but some basics, seem to me that can maybe make a meaningful difference and move the needle. Chris, what are your thoughts? I know you've got some, you were talking earlier before we jumped on about challenge healthcare
I think,
in West Virginia.
I think the study makes a really great point in that this is about relationships amongst the team. We all understand that multidisciplinary team care is what gives us the optimum outcome for our patients, and then relationships with patients and their provider teams. And what better relationship to start with than a primary care doctor that's already been established before that patient came to the ER or got referred in from the outside. So I think we all too often call our MDTs, our pathologist, our neuropsychologist, our neuroradiologist, our radiation oncologist, but we leave the PCP out. So I applaud you for pointing that out, that it is really an important facet. It gives the patients confidence and some relief that somebody may be their advocate that they've known for a while. And to my one question I had for you was, how many of those PCPs were already previously established, or have you seen there's a reluctance for a patient to get a PCP after coming into an ED with a diagnosis of a GBM? Because personally, I think they're more concerned about learning the names of the people that they have to get treatment from than finding a new PCP. And how do we overcome those obstacles in trying to get a PCP for somebody that's going to help them with the non-neuro-oncology side of their medical care?
Yeah, that's a really great question. So we actually, I did look at what percentage of patients had a PCP already established prior to starting adjuvant therapy. And it was most of them. I don't have the number. It was upwards of 80%. Interestingly, we also did analyses looking at if the PCP was affiliated with our institution or elsewhere, and if that impacted these outcomes, and it did not. So I think that's really important, that the PCP doesn't necessarily have to be located with our institution or have some relationship with the surgeon or the oncologist for this effect to occur. And as far as trying to establish a new PCP after the diagnosis of GBM, we didn't look at that in this study, but I do think that that would be an interesting outcome to study in future studies.
And there are models in the surgical oncology, general surgery literature that show that try to address that question specifically. It is a little awkward maybe to establish with a random PCP afterwards. Like I have a lot of other, the patients are thinking I have a lot of other things going on. But what has often been done is there will be a nurse practitioner or a physician assistant within oncology that will sort of play that role of being a conduit for multiple services, and it seems to be that for patients and families that's a little bit more of a digestible kind of a thing. At least it's broadly within the same network, but serving that role of trying to be a touch point.
Yeah, thanks, guys. I gotta tell you, part of the reason I chose this article originally is because we did a little bit of homework here locally, and we realized that a lot of our readmissions were happening in the first week after surgery. We have kind of a regular national percentage, but everyone wants to get their readmissions lower, and we saw within a week. And we looked at that data that primary care docs can help with this and getting a follow-up. And so we have an initiative now where we're making sure that if a patient doesn't have a PCP, they're set up with one and they see one within 7 to 10 days after discharge. And so I've been using your data to support the initiative. And I appreciate it. And so, guys, it's been a great half hour. We like to keep it short and sweet. Thanks for coming on, and we look forward to your next paper. Always a pleasure to see Jason and Chris, and always a pleasure to have you back, Raj. And Megan, nice to meet you.
Thank you so much. Total pleasure.
Great work. Thanks for joining.
Thank you all.
See ya. Bye-bye.
Have a great afternoon. Bye.